I am going to give the next presentation, which is on acute mesenteric ischemia. And there's a little bit of overlap with Eric's presentation, but I think that's fine because I think some of the points we make are a little bit different. Here are my disclosures. Now, acute mesenteric ischemia can be on the basis of vascular occlusion, and when it is, it's in the vast majority of cases due to arterial occlusion. But in a smaller percentage of cases, mesenteric venous occlusion can also result in bowel ischemia. More commonly, though, it's due to non-occlusive disease, and this is usually due to a low flow state, most commonly in patients with severe cardiac disease or with end-stage renal or liver disease, or just in patients who are severely ill and hypotensive. In a much smaller percentage of cases, it can be due to acute vasculitis. And the third major category, as Eric showed you earlier, that can cause acute bowel ischemia is a mechanical cause, and in the vast majority of cases, it's bowel obstruction, small bowel obstruction more commonly than colonic, but trauma can also cause bowel ischemia. Now, one of the things that's very important when we are diagnosing, making a diagnosis of acute bowel ischemia, it's important for us to go beyond the diagnosis and try to determine the specific etiology, because that has a very important influence on patient management. So, for example, if it's due to occlusive disease, then thrombolysis, embolectomy, percutaneous angioplasty, or even in some cases, emergency surgical bypass are the treatment options. Whereas if it's due to non-occlusive disease on a low flow state, then pharmacological vasodilation is the treatment of choice. If it's due to vasculitis, then patients are generally treated with immunosuppression. And of course, if it's due to bowel obstruction, then surgical decompression is the treatment. Now, with regard to technique, there really isn't too much to be aware of. I think the most important thing is that we don't want to give these patients a positive oral contrast agent because we don't want high attenuation material within the lumen of the bowel, which interferes with our ability to assess enhancement of the bowel wall, which is critical in these patients. So we either use no contrast, or if you want to use an oral contrast, it should be either water or a neutral agent such as volumen. Now you'll notice that I've listed here doing both arterial and venous phase images, and I think when we specifically suspect bowel ischemia, it is helpful to have a good arterial phase, but it's really not absolutely necessary. I think that you can get good evaluation of both the arteries and the veins with a good portal venous phase set of images. But if you are going to use arterial phase imaging, then it is helpful to use bolus tracking for appropriate timing. Now here's a patient with SMA embolism. You can see lack of enhancement of this atherosclerotic SMA. And here on the curved planar reformatted image, we can very nicely see the embolism within the SMA. Now, much less commonly, mesenteric venous thrombosis will result in ischemia, but when it does, it's generally very extensive and occlusive, as in this case. We can see extensive portal venous and mesenteric venous thrombosis, and the resulting segmental bowel wall thickening and mesenteric edema indicating the bowel ischemia. Now here's another patient with SMA embolus or SMA thrombosis, which we see here, but I want to point out several other important findings in this case. One is that the bowel, let me go back. One is that the bowel is very dilated, and so paralytic ileus is a very common associated finding in patients with acute bowel ischemia. The other thing is that the bowel wall is extremely thin and very poorly enhancing. There's almost no enhancement of this bowel wall, which is an ominous sign of inadequate arterial blood flow. And then the final thing I want to point out in this patient is this high attenuation material layering dependently within these dilated fluid-filled bowel loops, and this is hemorrhage, which I think is an underappreciated associated finding that we see quite commonly in patients with acute bowel ischemia. And here is just one other example of that. This is another patient with extensive mesenteric arterial thrombosis involving the celiac axis, the SMA, and the IMA. And again, we can see that the bowel is diffusely dilated and there is hemorrhage within the bowel lumen. Now, the key finding in patients with non-occlusive acute mesenteric ischemia is arterial vasoconstriction. And the reason for that, and we can see that here, notice that the SMA is patent, but it's extremely diminutive. And what happens is that the body's protective mechanism when there's inadequate blood flow, when there's severe hypotension, is to maintain blood flow to the heart and to the brain and to clamp down on all of the other circulations, including the mesenteric circulation. So these vessels are very, very attenuated, but again, notice in this case the marked dilation of the bowel loops diffusely and very poor bowel wall enhancement. Now, this is a beautiful example given to me by Dennis Foley at the Medical College of Wisconsin in Milwaukee of the CT angiographic appearance in a patient with non-occlusive mesenteric ischemia. And so what we're seeing here is that the proximal portion of the SMA looks pretty good, but as we get out more peripherally, we see the typical pruned appearance of these more peripheral mesenteric arteries due to arterial vasoconstriction. So a beautiful demonstration of that appearance. Now, of course, as Eric showed you earlier, as we get more advanced with bowel ischemia, we may see pneumatosis, mesenteric venous, and or portal venous gas, and it's very easy to make the diagnosis in this case. And in these cases, these patients almost always have already gone on to bowel necrosis. Now, mesenteric ischemia due to vasculitis has a very different appearance. And the distinguishing features in this group of patients is that, number one, these are usually a younger group of patients, often women. Very importantly, the duodenum is often involved, and the duodenum is very rarely involved in any other form of acute mesenteric ischemia. And often the small bowel and colon are both involved. So it's a more diffuse systemic type of process. And here's a nice example of a young man with abdominal pain, bloody bowel movement, and a rash who has all of the typical findings of acute mesenteric vasculitis causing ischemia. Here we see multiple thick-walled jejunal loops with mucosal hyperenhancement and submucosal edema. Notice that the duodenum is involved, a very important finding, and the colon is also involved. And we see a couple of loops that look relatively normal, so we can have some skip areas as well, all of the typical findings. And this is a patient with Henoch-Schönlein purpura. Here's another young woman who has lupus, and she also has the typical appearance of acute mesenteric vasculitis with bowel ischemia. Notice the extensive bowel wall edema, mucosal hyperenhancement, ascites, mesenteric edema, but notice that all of her major mesenteric vessels are widely patent. Now, the final category, major category that results in bowel ischemia, as Eric presented to you, is bowel obstruction. More commonly small bowel, but it clearly does occur with high-grade colon obstructions, as I'll show you in a few moments. And only about 10% of small bowel obstructions have associated vascular compromise. The mortality rate can be very high, and many of these are due to closed loop obstructions. So Eric has already presented to you some of the important ways of diagnosing a closed-loop obstruction. Here's a nice example of a patient with a C or U-shaped dilated loop of bowel, one of the very typical appearances, and this is usually due to adhesions or a small bowel volvulus. Another very important configuration of a closed-loop obstruction is shown in these two patients, which is a radial ray of small bowel loops with the mesenteric vessels converging toward a single point within the mesentery. And this is characteristic of a small bowel volvulus. Now here's another patient with a closed-loop obstruction that is not quite as characteristic, and that's because the segment of bowel involved in this closed-loop obstruction is very long. But I'd like to point out another finding that I think is very helpful in making the diagnosis of a closed-loop obstruction, and that is these two adjacent focal collapsed segments of small bowel, which represent the point of the obstruction, the point in this case at which the bowel has twisted. But again, notice that within this very long closed-loop obstruction, we again see dilation, the bowel is fluid-filled, the wall is very thin, and there's very poor enhancement as compared with these more proximal, normally enhancing bowel loops. Now, colonic obstruction can also result in ischemia, and here is a woman who presented to our emergency department with this high-grade obstruction due to an annular constricting colon cancer, very dilated cecum and ascending colon, but very importantly, notice the stranding and fluid adjacent to the cecum. And there's also a little bit of thickening of the bowel wall here. And at the very least, these findings represent bowel ischemia, but in many cases, these patients have already gone on to perforation, which was the case in this patient. Now, here's another patient who looks very similar. Here's the obstructing colon cancer. Again, very dilated cecum and ascending colon, but notice that this patient clearly has already perforated, so very easy to make the diagnosis. Now, this is the last patient I'm going to show you. Again, looks very similar. This was an elderly woman who came into the ED with severe abdominal distension and pain. And here is her high-grade obstructing cancer with a very dilated cecum and ascending colon. But notice in this case, she also has peritoneal fluid, including this high attenuation fluid adjacent to her cecum. And here is the pre-contrast image. Here's the arterial phase image showing active extravasation from the wall of her colon. And so this is another example of hemorrhage in association with bowel ischemia, in this case due to a high-grade obstructing colon cancer. So in summary, when we are evaluating patients with suspected acute mesenteric ischemia, it's important to use appropriate image acquisition and reconstruction techniques, and very importantly, that includes not giving any positive oral contrast material. It's important for us to go beyond the diagnosis and try to determine the specific etiology, because that drives patient management. And I think it's helpful to look for hemorrhage, because I think that can, in many cases, tip us off to the correct diagnosis. And one final thing that we haven't had a chance to talk about, and I would reiterate what Eric said earlier, is that it's very important, if we suspect acute bowel ischemia, for us to communicate that information to the referring physicians in a timely manner, because it is the bowel necrosis that results from these ischemic changes if the diagnosis is delayed or if treatment is delayed, that causes the increased morbidity and mortality in these patients. So it's important for us to make sure the referring physician knows what's going on. And I thank you very much for your attention.